Good morning and welcome to our program on health disparities in a time of COVID. And welcome to what we hope is a series of ongoing conversations between community leaders in St. Louis and Kansas City. Glad to have all of you here today. Welcome. I'm Steve Kraske. I'm host of the public radio program Up to Date here on KCUR in Kansas City. I'm also a journalism professor here at UMKC. We're going to begin this morning in just a moment with a presentation from Dr. Alex Garza, and I'll follow that up with a panel discussion with experts from both sides of our state line on this very important topic here in Missouri. I'll begin with Dr. Garza, Dr. Alex Garza, who is the Chief Community Health Officer for SSM Health. He's going to talk to us about the state of public health in Kansas City and St. Louis. Fasten your seatbelt, folks. This may be something of a sobering conversation, but I should point out that Dr. Garza is a graduate of UMKC, which makes him a proud kangaroo. Dr. Garza, welcome. So nice to have you here today.
Great. Thank you, Steve. And allow me to go ahead and share my screen here, and we'll get into presentation mode, and we'll get this kicked off. So if Steve, you could just let me know whenever it looks like it's coming up.
Dr. Garza. Looks good.
Okay, great. Thank you. And thank you so much for the invitation to speak with you all today. As Steve mentioned, I'm a proud kangaroo. I spent a number of years in Kansas City down at Truman Medical Center and worked at the health department as well. And so in preparation for this talk, I did have a conversation with Dr. Rex Archer, who's my former boss and a good friend. So in talking about health disparities in COVID-19, it's a complex issue. And so what I really wanted to convey is that it is more than just talking about health disparities. It's really, it's the entire environment that is surrounding disparities that has contributed disproportionately to COVID-19. And I hope to weave in a couple of stories from some of my other experiences working in the federal government, as well as in public health and as an emergency physician. So let's go ahead and get started here. And so I start off with this quote from my former boss when I used to work in the federal government. And President Obama had a really great way with words. And so this was his quote about disasters. And I will read it. When disaster strikes, it tears the curtain away from the festering problems that we have beneath them. And hopefully I can show you why this is important when we're talking about COVID-19, which I would argue is a disaster. So before we get to that though, this is a journal that's put out by the Catholic Health Association. So I work for SSM Health in St. Louis, which is a Catholic not-for-profit health organization. And I was asked just about a year ago to contribute to this magazine because of the work that I had done in the military, in disaster preparedness, in emergency medical services, and at the Department of Homeland Security to write an article about disasters. And the reason why I highlight that is because it was just about a year ago when this was published. And so the topic that I chose was guns, germs, and healthcare. And the reason why I did that is as we continue through this year, unfortunately, we have a significant amount of violence that's occurring in the St. Louis metropolitan area, particularly amongst young people. And talking about germs because I did a fair amount of work in biodefense for the federal government. But I tried to bring this all together underneath a rubric of how does this all fit together with social issues. And so unfortunately, I was a little bit precedent about this, and I picked a couple of quotes out of this article that have been referred to in some other venues where I've spoken. And so this one was, I think, particularly precedent. However scary a deliberate biological attack seems, nature is much more prolific at developing and spreading infectious disease disasters than a nefarious state actor. The severe acute respiratory syndrome pandemic is a good example of how disease is no longer isolated. It can travel widely and rapidly. In the Ebola crisis in Sierra Leone and Guinea in 2013 offered a similar lesson on how fragile states, local culture, and environmental issues, when combined with a highly transmissible and lethal infectious agent, can bring about devastating effects. And there was reasons why I chose those words. fragile state, local culture, and environmental issues, because it isn't just about the infectious disease, it's about the environment where the infectious disease is found. And the other quote that I pulled from this is this one. In many ways, however, infectious diseases and similar to gun violence, they affect the poor and the vulnerable disproportionately and can span from small intense episodes, such as a case of meningitis or sepsis, to full-blown disasters such as H1N1 or Ebola. Now, little did I know that less than a month after this article was published that we'd be in the throes of the world's worst pandemic in over a century. So let me bring this back around to three things that I want to cover today, and it's going to go pretty rapidly, but I do want to be able to cover enough and then leave enough time for Q&A. So three things: the current status, what risk means. This is deliberate from when I spent time in the federal government, and then talk about health disparities and maybe some parting thoughts. So what is our current status? And so I pull my data from the New York Times and from some other data sources. So you're going to hear some data a little bit later today in the Q&A, but it's directionally the same. So just so you know, in case there's a couple of differences in the numbers. This is a current map of the United States. This is not the political map. This is a map from the New York Times that shows where the hotspots are across the country. And you'll notice that the vast majority of where spread is occurring is here in the Midwest. Unfortunately, that's where all of our hospitals are as well within SSM Health. In particular, though, you'll notice that Missouri in the middle of the map is also highlighted as a hotspot. So just to share a little bit of numbers with you, 7.8 million cases in the United States to date. 215,000 dead. And again, this is likely an underestimate. There's a journal that came out a couple of days ago in JAMA showing the excess mortality. And so we're probably undercounting the number of dead from COVID-19. This is the state of Missouri. So the state of Missouri, as I said, is a hotspot for COVID-19. So let's look at their numbers very quickly. 148,000 cases that we know of. We'll talk about the database problems here in a minute, which when you normalize it to the population is about 2,300 per 100,000. And then around 2,500 deaths. Again, when you normalize this, it's about 41 per 100,000. And then we have two major metropolitan areas within the state as well, St. Louis and Kansas City. And if then we start drilling down and looking at the particular data within both of these, we see 13,000, about 13.5 in Kansas City, which roughly gets you to about 2,800 per 100,000, 168 deaths, giving you a death rate of around 34 per 100K. Now, St. Louis is a little bit different from Kansas City geographically. We have a city, which is the only city in the state, which is considered its own county, and St. Louis County. So I included both of the numbers. So this is the city number, about 7,400 cases, about 2466 per 100K, 217 deaths, which works out to about 72 per 100,000. And in the county, which is much larger than the city, it's about 3 times larger, 25,000 cases, 2,500 per 100K, 839 deaths, which works out to about 84 per 100,000. There's some disparities, as you can see, on the different sides of the state. So let's talk just a little bit more about the environment now. So I want you to remember these two numbers, $5.86 and then 15.6%. $5.86 is the amount per capita that the state of Missouri pays for public health. And that just happens to be the lowest spend in public health in the United States. 15.6% is the percentage of the population that lives below the poverty line. Now, you'll be asking questions on why I'm talking about this, and hopefully this will become clear in just a second. The percent below the poverty line in St. Louis metropolitan area is around 12%. In St. Louis City, though, it's around 23%. And the ratio between African Americans of the Black community to the white community that live below the poverty line is 3-to-1. Kansas City metropolitan area is around 9.7, but again, the ratio is the same, around 3-to-1. So that's the statistics. That's where we are right now in the state of Missouri, Kansas City, and St. Louis. I'm going to talk a little bit here about risk. And the reason for that is a lot of times when we talk about risk, we talk about it from a health consequences point of view. So what are the things that put you more at risk for COVID? But what it really doesn't cover is the entire environment. And so I revert back to my days at Homeland Security when we talked about risk and use this equation, this threat times vulnerability times consequences. So think about it this way. Threat is really this. It's capability times intent. So typically in Homeland Security, we were talking about terrorism. But you can think about a virus in the same way. So the virus definitely has capability. Everybody by now is familiar with this picture. So it's capable of human-to-human transmission. That's what makes it so dangerous. And its only intention is to replicate in a susceptible host. So if you combine those two, you have a formidable threat. Moving on now though to vulnerability, and I think this is where the crux of the argument is. If you think about vulnerability, there's a couple of different ways to think about it. One is from the environment. So is there a high level of contagion? If you are interacting with the public and if there's minimal mitigation strategies, that creates a high environment for vulnerability. The other one is personal, and this is the one that you hear a lot about because this is what the CDC will put out. These are the groups of patients that make you more vulnerable for having a poor outcome from COVID-19. However, personal medical issues alone don't put you at more risk. It's the combination of different things that put you at more risk rather than just the medical issues. So how do I highlight this? So this is some work that we did with St. Louis University, and I'll apologize for not having as many maps in Kansas City, but this is work that we had done with St. Louis University. And so this is looking at during shelter in place. So the easy way to think about this is red is bad, dark blue is good. So red means that you were in a high risk position, which as you can see here is food service employment, and you had to travel during shelter in place. Blue means that you did not work in the food service employment industry and you did not travel, so dark blue. So as we know, the food service is a high public interaction. And early on in the days of the shelter in place, we didn't have the mitigation strategies in place as well, such as universal masking. So I'm going to walk through a couple of different industries here. So food service, as you can see on this side, the red is all North City, which is where we had a high penetration of COVID in the St. Louis area. The dark blue is out in the county, mostly in the affluent areas, where there's very low penetration of COVID. So what about health support? So these are people that work in nursing homes, long-term care, other areas. Again, these are people that were expected to go to work and had to travel quite a bit. So why do I mention travel? That's because of having to use public transportation, which again, is a risk, especially before universal masking was put in place. But again, you see that disparity between what was going on in the city and the more affluent areas of the county. Now, how about professional employment? So let's flip this now. So more professional employment out in the affluent areas, less in the inner city, but where it was, there was more travel involved. And then manufacturing is along the same lines. Low manufacturing out in the county or the more affluent areas didn't have to travel as much. More people working in manufacturing in the inner city that did have to travel quite a bit. And this played out in Kansas City as well. When I was talking with Dr. Archer earlier today, he was telling me about two of the major outbreaks that occurred. One was at St. Joe's in the meatpacking plant, and the other one was at the Aspen Products plant. And these both had similar stories where large groups of people were having to travel from the city to these different plants, so high travel, and it was manufacturing work. And so that put them at high risk for outbreaks as well, and that's exactly what was seen in Kansas City. A couple of other things just to really highlight the differences. So this is daily average change in staying at home. And all of these show the proportion of people that were able to shelter in place. And you can say the same thing about quarantine and isolation. The people that we're putting at the highest risk are the people that have the least resources in order to maintain stability, whether that's income or being able to shelter in place at home. So again, red is meaning they didn't change, blue means it didn't really change that much. They still had to travel. Going through a couple of other maps, leaving for part-time work, we saw the same thing. Leaving for full-time work, it was the same thing. So although there was shelter in place, people that had specific jobs still had to travel, meaning they were putting themselves at risk. This was a little bit different. This is time spent at home, so it flips there. So this is exactly the opposite. People that could not spend time at home were in our at-risk groups, whereas people in the more affluent parts of the county were able to spend time at home. Another risk factor, people that had means were able to shelter in place, where people that didn't could not. So that was risk. Now that was vulnerability. Now let's talk about consequences a little bit. So there's different types of consequences. There's lost wages, nutrition, education, as well as morbidity and mortality. The wages, nutrition, education comes from closing of schools and other things. Morbidity and mortality are a little bit more closely looked at just because of available data. So let's look at that data really quickly. So I pulled this from the Kansas City, Missouri Health Department's website. And it's clear that you can see the death rates and the hospitalization rates are disproportionate to the Hispanic community and the Black community than they are to the white community. And it's for all of those reasons that I just depicted in the risk slides. These are slides that we shared with our public back in July. And when I reran the numbers, they were about the same. So this is the St. Louis area and the impact on the Black community. 4 times more likely to test positive, 2.5 times more likely to be hospitalized, and 1.5 times more likely to be admitted to the ICU. So this is a cartoon that we share as well. So if you look at this, 18% is the population that's Black in the St. Louis metropolitan area. However, they make up over 50% of people that test positive and around 60% that are admitted to our facilities. If you expand this to our transferred to the ICU and died, it becomes a little bit more even with around 50-50 of people that die within the hospital. But that's the wrong way to look at it. You have to look at the burden on the population. And this is what it equates to. So this is the disparity that we see. 55 of every 100,000 Black people in the St. Louis area are dying because of COVID, whereas 15 of every 100,000 if they aren't Black. That really shows the magnitude of what COVID is doing to this community. So let me briefly talk about health disparities, and then I'm going to wrap this up. And this is a wheel that I consistently use when I'm talking about health disparities. And that is to highlight that health disparities is not about the delivery of medical care. This is what are called the social determinants of health. And as you can see here, only medical care provides around 11% of total health of the individual as well as the community. So what is the other 90%? Well, that involves the physical environment, so housing. That also involves personal or individual behavior, but a lot of that is really hidden underneath things like poverty. So being able to get a good education, to be able to access good food, things like that really impacts individual behavior. If all you have is quickie marts that sell cigarettes and liquor in your neighborhood, then that's going to influence your individual behavior. And then other things like social circumstances play a big part in the overall health of a person and the community. And then lastly, there are things like genetics and biology. But the point to bring up on this is that it's not just the delivery of healthcare that influences health. In fact, that plays a pretty small percentage. It's all of those other things that really put you more at risk for things like a pandemic. So this was, again, another screen grab from the Kansas City, Missouri Health Department talking about some of the disparities that put people at risk for COVID-19. So as I mentioned, public transportation, being able to pay for basic necessities, unemployment, these are all things that contribute to putting people at risk for COVID-19. So this just came out today, and I thought this was a rather striking display of the challenges that we face, not just in St. Louis and Kansas City, but across the United States. And this is mortality compared with other economically developed countries. And if you take a look at this, we have one of the highest COVID mortality rates across the world. And we share that with some of these other countries. But when you compare our death rate with the other countries, especially over time, it becomes increasingly apparent that we have issues that we haven't dealt with that don't exactly involve the pandemic, but there are other issues that have to be solved. So again, it's not just about the delivery of medical care or even health disparities. It is about the entire environment that surrounds an individual and a community that contributes to why certain populations are more at risk for poor outcomes due to COVID-19. And so I would argue that it's not so much health disparities, but it's social and economic disparities that contribute to the health disparities, or that actually produce the health disparities. And if we ever want to come across a solution to the pandemic, we have to address these things first. This was an article that was in the Wall Street Journal just 2 days ago. And I found it striking because it said lessons for the next pandemic. And they're talking about things like spread, smarter lung scans, and screening blood samples, where my contention is we have to fix a lot of other things other than just come up with better testing. That is a reactionary move rather than a proactive move to be able to handle a pandemic. And so I would just bring that back around again to my former boss's statement. When disaster strikes, it tears the curtain away from festering problems that we have had beneath them. We have to address the festering problems, otherwise we're going to keep having disasters like the next pandemic. So thank you, Steve. That ends my presentation, and I know that we're going to come back to some questions later on. So thank you.
That's right. If you would, stop the share, that'd be great. Okay, great. Well, Dr. Garza, thanks so much. I think that sets the table pretty well for our conversation here today. What we're going to do now is Dr. Garza is going to disappear. He'll come back later on for the Q&A portion of our conversation. I want to introduce our panel. We're going to discuss some of the issues that Dr. Garza just laid out, and let me introduce them to you now. Diego Abente is the president and CEO of Casa de Salud. That's a healthcare resource for the foreign-born community of metropolitan St. Louis. Diego, it's nice to have you. Welcome.
Thank you. It's great to be here.
Dr. Jeanette Berkeley-Patton is director of the UMKC Health Equity Institute. Dr. Berkeley-Patton, good morning to you. Risa Rollins-Easley is the chief of staff for the St. Louis Regional Health Commission. Risa, good morning.
Good morning.
Kiana Thomason is president and CEO of the Health Forward Foundation based here in Kansas City. Kiana, nice to have you too.
Thank you, Steve. Good morning.
Well, Kiana, I'll start with you here. Yesterday, if you can believe it, we passed the 7-month mark since the national state of emergency was declared in response to the COVID-19 pandemic. Since then, this country, as Dr. Garza just laid out, has seen 7.3 million confirmed cases and 215,000 deaths altogether. In Missouri, those numbers are 144,000 cases and roughly 2,500 deaths. So my question, in your opinion, what is the key to turning the corner on this virus in our communities?
Sure. Well, there's certainly the obvious tactics that we're all quite familiar with. It would help to have a national mask mandate, a solid national strategy for testing and tracing, and clearly a safe, efficacious, and equitably distributed vaccination for COVID-19. So those are the obvious ones. But I'd also say leadership, trust-based, equity-centered leadership will help us turn the corner and would help us move beyond recovery into resiliency. So what does that look like? First, it looks like leadership that trusts the expertise and guidance of our scientific community to get us out of this mess, this pandemic. It also looks like leadership that is seeking to expand access to health care during a pandemic and a national health crisis, and not dismantle a law that would result in the loss of healthcare for over 20 million people, many of whom are at higher risk for infection of COVID based on the data that Dr. Garza just shared, because they're in essential working jobs and positions and have continual contact with others, or they are in socioeconomic conditions that place them at greater risk of mortality from the virus. It looks like leadership that understands that communities of color have been hardest hit from this pandemic, and that the health injustices that stem from that are socioeconomic and environmental in nature, as Dr. Garza just grounded us in, and looks to go upstream and fix those issues and takes a reparative approach to policymaking to lift individuals out of the socioeconomic peril and conditions that they're in. It looks like leadership that has knows and acknowledges that there's high levels of mistrust among communities of color towards the medical community that's based in historical medical abuses. And knowing that there is a COVID-19 vaccination that's impending, that it's actively working to build trust in communities of color around the importance of vaccinations and addressing their concerns and skepticism about this. And lastly, it looks like leadership that's honest and transparent about the risk that we bear around this pandemic and has a risk mitigation strategy to help us turn the corner. So the obvious as well as trust-based equity-centered leadership would help us turn the corner.
We're going to talk about the historic distrust with the medical community in just a little bit. Diego, what would you add to what Kiana just said?
Yeah, those are all very great comments. I think I want to really double down on this idea of trust. A saying I've been thinking about and repeating often lately is that trust arrives on foot, but can leave in a Ferrari or on a Ferrari. And so reminding people that trust is something that's earned and is hard fought for in many cases, and that is easily lost, and understanding that the uncertainty that the virus has presented to all of us is something that is a challenge for folks in terms of giving their trust to organizations and people that they didn't already trust in. And so leaning on grassroots and leaning on community members and organizations who already have that trust is a must as we work up and as we lead from the top down, right? Because it's too late now to gain that trust, and we don't have the time based on what we know about how the virus spreads and its morbidity and mortality in our population. And I think that gets to something else I've really been trying to do a better job of, along with our partners, which is talking about these high-risk groups and talking about these issues that lead to higher risk of COVID morbidity and mortality in a way that's inclusive. And that's a lot easier said than done, right? We need to recognize that we all play a role in addressing these inequities that have led to where we are today, and that we all have a role and responsibility in addressing those moving forward. And so we need to give folks agency and empower them and help them feel like they are part of the solution, and stay away from the finger pointing, you know, and sort of making them feel like they're part of a problem, or they're sort of dragging the country down in our sort of national response to COVID. And again, that's a lot easier said than done. And I think in particular for folks whose first language isn't English and whose first culture, if you will, is not the culture of the United States, we've got to understand that our response needs to be multifaceted and needs to be diverse and inclusive of these different cultures, because we need to speak to them in their quote unquote language, right? And again, these are all things that are much easier said than done. And so thinking about the sort of coordinated response in communities in a way that is accessible to people in their language, in their culture, in their communities is really important. I think makes a big difference in how people adhere to what's being asked of them in terms of preventing and protecting themselves from COVID. So I often say to folks, you know, what I hear from the folks that come to Casa de Salud who don't speak English or whose preferred language isn't English is they don't want to go to WebMD to find out, you know, about COVID, or even CDC or other websites. They don't want to have to Google it. They want to talk to a human being, and they want to share in the uncertainty and in the anxiety and the stress that we're all experiencing. And so thinking about this and bringing the numbers and the data down to a very human level, I think is very important in how we turn the corner as a country.
I appreciate that. And just a reminder to our viewers, if you have questions, you can go to the Q&A button at the bottom of your screen and enter those. We'll get to those questions in just a little while here. Dr. Berkeley Patton, I want to come to you with a question about this notion that we're entering cold and flu season here. in the last couple of years, fewer than 4 in 10 Black, Hispanic, and Native Americans adults have received an influenza vaccine. The COVID-19 vaccination, when it becomes available, will be especially important to communities of color that are being disproportionately affected here, as we're talking about today. But to get this done, and we've been talking about this a little bit, public health officials and providers are going to have to overcome a whole range of barriers to vaccination among people of color. Among them, this notion of this historic legacy of abuse and mistreatment by the medical system. So, piggybacking on comments that have already been made here, what's the path forward? How do we increase vaccination rates in these key communities?
Hi, everyone. Thanks for having me. The points that have been raised are really important, and the medical mistrust is, that is one of the key critical issues that has to be addressed. And it's not unfounded. Studies show that for people of color, that many times they receive a worse quality health care, that they don't believe that they're being respected in many cases by health providers, and that there are other issues that come into play, like just even being able to access health care. And much of the data has been shared on the social determinants, those things, those barriers that get in the way that limit access to health care. So when we're talking about vaccination, there's a wide range of things that need to be done to be able to increase the uptake in communities of color. One of the most important ones is going to be making sure, just as what was mentioned earlier, that we have key leaders who can communicate the importance of the vaccine and the safety parameters that have been put in place around the vaccine. But even at that level, we may need to do some work in convincing our community leaders. I know in conversations that I've had in Kansas City with some, particularly Black leaders, they've said, hey, I'll wait for the second round because I don't, necessarily trust what's out there. We know we've had many mixed messages around COVID-19, and that's pretty much fueled over into, beliefs about the vaccine as well. And so we've got some work to do to not only train our community leaders and the messaging that needs to be put forth, but also in convincing them about the importance of the vaccine as well. And if ever a time that we needed to put into play use of our community health workers, our lay health workers, those people who can interact directly, just as Diego had mentioned, with our community members, this would be the time to be able to build that trust. And so we have to be really strategic in who's delivering those messages. Those messages need to come from people that are highly trusted, people that others are interacting with often, and people that are highly respected. And unfortunately, for many of the public health messages that are getting out there, they may not be landing because they may not be communicating these health messages and the importance of COVID-19 testing and the uptake of the vaccination in ways that really communicate to our populations.
Well, Risa, it sounds like, based on what Jeanette is saying, based on what Diego is saying, that we've got a lot of work to do here in a short amount of time. Is it getting done? Are you confident that it's going to get done?
So I want to just step back just for a second to touch on two things that I think respond well to what my colleagues are saying on the panel. I think one principle that we can look to is the principle of Sankofa. And I like to bring that into conversations every opportunity I get. And this principle thinks about looking to the past to be able to establish a path forward. The way that we move forward is to acknowledge, as Dr. Berkeley Patton was saying, the injustices that have happened in the past. We can't come into the conversation and say, hey, everyone, line up to get a vaccination, without first acknowledging the deep mistrust that is founded historically on experiences that have been passed down for generations. And it's not distant experiences. There are people that are with us, that are walking with us today, that within their lifetime can point to instances in which there was a medical malfeasance that creates the seeds of mistrust within Black and Brown communities. So we have to first acknowledge, and we have to be very diligent about discussing what we're doing differently and how we're going to be transparent and accountable. And we do that by building relationships, sustained, committed relationships in times when we don't want anything. We build relationship with community when there isn't an ask. And that network and that relationship that's built has to include, in my opinion, four categories within our panel of expertise to help us think through and plan our path forward. We know that we have to include researchers and the best data that's available. We are getting pretty good at that. We know that we have to include our executive and legislative leadership in the conversation to be able to release the resources that is needed in order to move forward. But where we sometimes drop the ball is ensuring that our panel of experts include the frontline staff who are fighting these issues on a daily basis, the nurses, the community health workers, the social service sector who is partnering with the medical field in order for this to be done. And then the other piece that I think we sometimes drop the ball on is the community experts with lived experience. I am an expert in my experience, and so I can help you. I can tell you how we move forward and how we build sustained trust, because we're doing it in the times where there isn't crisis and when there isn't a need, and we're carrying those relationships forward. And I think we have some exciting examples of how we're trying to lean into that in this moment. And I would love to share some of that with you, but I'm conscious of the time, and I can share some of that with Prepare STL and a new effort with Vaccinate STL to give more information to folks. I think we also need to trust that the community is wise and knows what their needs are. And if we are willing to share power and transparently give information, folks will make the choices that are the best for themselves, for their families, and ultimately for our communities. And we have to do that by being transparent, by acknowledging where our missteps are, and being willing to fail forward, to lean into this process of transforming our system in ways that, again, share power and expertise and allow us to learn from community in building respected relationships.
Risa, stay with me for a minute because I want to talk some history here. You know, you go back 100 years, the Spanish flu pandemic, a lot of folks didn't think people of color were affected at all. Move forward 100 years, obviously, as we're talking here today, Black and brown populations being heavily affected. So what steps do we as a society need to take today to ensure that this doesn't happen in the next pandemic here?
Oh, I'm so glad you asked that question. So I want to take a little bit of time just to give you a concrete example. I don't know, I'm a tangible person. I want to put some handlebars on it for you. So in the St. Louis region, Dr. Garza shared some powerful data around what the experience has been. We know that the first deaths in St. Louis City and County were Black women. But when you look at where the first testing sites in the St. Louis region were, they were in West County, not in North St. Louis City and County, where, as you saw the maps, where there is a higher proportion of Black and brown communities, but out in West County. So leadership then, in thinking about what is the impact of this systemic inequity that is baked into our system, we're able to say, you know what, we need testing centers in North St. Louis City and County because that's what the data is telling us. That's where the need is. And so we were able to then develop, the Regional Health Commission has received funds through our partners and our health departments to establish testing centers through our federally qualified health centers in North St. Louis City and County. But then we understood, you know what, that's not enough. The message isn't getting out, and our community is not trusting the messages, again, because there's no relationship. So then we were able to build Prepare STL, which is community leaders on the ground with trusted, respectful relationships that have existed over time, that are able now to take the most current, up-to-date, accurate data to the community to say, here is what we know. Here is the information that we're giving to you for you to be able to act on, so that we don't have another instance. If we are going to really look full in the face and pivot, because this is our opportunity to pivot from the systemic inequity that lead us to the disparate outcomes that we've seen 100 years ago and that are repeating themselves today, it's only going to be through expanding that table and the conversation to the folks who are most impacted, trusting that wisdom and leadership, and being willing, again, to fail forward. We have to be willing to try until we get it right. We can't be bound by our fear of failure. We can't be bound by our fear that someone is going to call us out because we misspoke or it was a misstep. We have to be willing to say, we don't know what we don't know, but we do know that you have expertise that we need to learn from, and we are willing to share this power because these outcomes are unacceptable, and we as a community have decided that we're not going to allow this to happen a moment longer.
Tiana, let me come to you now, and this might be a good time to mention that the Health Forward Foundation recently announced a shift upstream that will allow it to address the changes and issues that lead to poverty. How do you specifically see this change affecting the work of the foundation, Kiana? And what difference is it going to make in the lives of those in the metro area when it comes to a post-pandemic world?
Sure. So you're right. I recently shared the new vision around achieving health equity through economic equity and economic inclusion. So as Dr. Garza mentioned earlier, these are not just health disparities. I say health injustices. These are economic injustices that have created health injustices. And so understanding that and knowing that what underpins poverty, which is our target population of people living in poverty, those who are uninsured and underserved, what underpins poverty is income and wealth inequality and structural racism. So knowing that, how do we calibrate our strategy and our positioning to go further upstream and address asset building opportunities that build income and build wealth in communities. So as we continue to be an anchor institution around healthcare access, we also need to give equal attention to the levers that build assets, power, money, and resources in communities that are uninsured and they're living in marginalized conditions. So educational opportunities, workforce opportunities, home ownership, and affordable housing opportunities. All of those are drivers, if you will, for economic mobility. And we know that we can't play in all of those spaces, so we have some decisions to make. But we also know that there are policies that really underpin this more so than our grant making can ever be effective in addressing. So we expect our policy footprint to broaden and to have more of a focus on the social determinants of health, and it's more broadly understood now as the social political determinants of health. That reframe from social to political determinants of health allows us to be accountable for the decisions that are made that create the policies that either construct equity or deconstruct equity and equitable systems around those areas of education and home ownership and financial prosperity. And so as we think about who our leaders are of the future and societally, how do we need to reposition? We must begin to understand that the daily decisions that we are making, the elected officials that we are putting in place, they're decisions that are creating just or unjust systems. And so that's from a reframe perspective where we need to head. So in practice, that means applying a health equity and a race equity lens to our policy making, and that will be important for our bi-state community at a local and state level, but it's equally important for federal policy making.
I want to encourage, again, participants to go to the Q&A button if you have questions for our good panelists here. Diego, I want to come back to you and sort of push this idea of messaging and communication strategies that you're using to talk with people in St. Louis and Kansas City about this pandemic. Tell us about that a little bit.
Yeah, so I have to come back. There are obviously a couple of really important themes that are sort of rising to the top here. And one of them is this idea of leadership in action, right? And like Risa she hit a nerve here with this idea that we can't confuse leadership with action. Leadership from the top, yes. Action from the grassroots in the communities also. They are not equally opposing, right? We need both of those things. And to just reiterate that you can manufacture a vaccine, you can manufacture treatments, but you cannot manufacture trust. and least of all in these types of times. So that goes into how we think about communications, right? The first thing we have to recognize as an organization that's been in the community for 10 years is that we have the trust of the population that we serve, and we have the trust of the partners that we've worked with. And so we've got to take that into the community to serve folks where they are in a timely way, understanding that COVID is affecting every facet of their life all the time. I mean, it's the reason why we're all looking at each other over a video feed instead of sitting in a room together, right? So we are all affected by COVID all the time, and we have to recognize that and recognize that it affects people differently, right? So our biggest problem is, can people hear us and see us? You know, other folks have much more pressing, real problems about food insecurity, about whether they got job security or not, about whether they're covered in terms of their healthcare needs. And so the way that we message is by recognizing that, hey, there are a lot of challenges out there right now. Tell us about those challenges and let us figure out where we can be of help and where we can bring in partners to provide their leverage expertise in solving the problems that you guys are facing on a daily basis. And so it really is sort of, the best message is actually listening versus talking at or talking to folks. Because folks, as the theme has sort of, again, come to the surface today, people know what they need. People have agency. People are smart. People, you know, we can't underestimate them in the way that we communicate with them. And that's the way that CASA has sort of developed its messaging in terms of just being very respectful, that folks can tell us what they need and we need to be responsive. And then sort of more particularly with folks whose first language, again, is not English or whose culture is not that of the United States, recognizing the diversity that exists in folks whose first language, for example, is Spanish versus English, which is my experience, right? There are at least 3 or 4 different ways that we can refer to a mask in Spanish, right? You can say mascarilla, barbija, máscara, and so nasobuco is another one which I didn't even know. And understanding that the way that we communicate with people makes a difference. So if I'm using a word that's common and that's understood, then I'm saving a lot of time from having to explain to someone, oh, here's what I meant to say to you about how you can help prevent the spread of COVID. So understanding that there are those nuances and that we have an extremely rich and nuanced community that wants to be spoken to and wants to hear that their culture and language is being respected when they're being, when information around COVID safety and COVID treatment is being shared with them is also really important. So, you know, we bake that into all of our messaging, and basically it's all about listening. It's all about using plain language so that we avoid mistakes and miscommunication, using a lot of audio visuals, and empowering and helping people feel like they've got agency when they're receiving the information from us, right? We're giving them what they need, the resources they need to be part of the solution. And, you know, we can't say that enough. And that's, I think, what we all need to hear, right? That we have a role to play and we are part of the solution.
Jeanette, what's your sense of who's sending these messages, and are they trusted folks or not?
Yes, so from talking to our community members, what we're hearing again is that they want these messages to come from people that they trust, people that they know. So we've been doing a lot of work in the African American faith community that has a large presence in the inner city area of Kansas City to develop messages that can be communicated with their church members and also with the community members that they serve through their outreach ministries. And so this whole process for us has started just as what was mentioned earlier with listening. You know, we believe also that people have their own solutions. People know how they want to hear this information. And so we've taken some time to really listen to our faith leaders and to their church members and the community members that they serve to understand what are their concerns, what are their issues, and what type of messages do they want to receive. And so in doing that listening, we've moved on now to developing some of our messages and actually starting with text messages and working with pastors in developing testimonials and developing sermon guides so that they can communicate these messages in formats that are naturalistic for their members. And it coming from, again, a trusted source, having that much more power behind it. And so we're starting there. We're starting with the faith sector and really trying to dig deep into getting these messages out through the faith sector. But ultimately, this is an opportunity for all sectors to pull together. This is when we need a unified force where the same messages are coming from the faith sector, from local businesses, from our schools and other places where the same message is, hitting home. And so that's where we are right now. And we just, again, believe that our community members have the solutions. And when we listen to them, and not just listen, but act on what we hear, because the other part of this issue is that our community has been to so many town hall meetings and so many listening sessions, and what they want to know is what's going to happen next. And so we have to be able to pull all of this information that we've been learning in these different listening opportunities and do the next thing and put some pieces into action, put some platforms into action so that we can really begin to message in our communities of color.
Well, let me roll on to the Q&A portion as our time is growing short here, and our once reticent audience is now coming through with a number of questions that look pretty good to me, and I want to throw them out. I think Dr. Garza is joining us again here, and I appreciate that. First question here, could you please name a few sources of data for researchers interested in working on measuring health disparities and recommending improving resource allocation policies to curb the problem? Risa, Dr. Garza, that makes sense for one of you?
Sure. Yeah. No. So it's a good question, and it's not a simple one to answer. And the reason for that is because of the complexity of the data that goes into looking at socioeconomic issues and combined with COVID. And so we've been very fortunate in the St. Louis area where we've been able to combine the clinical data from our major healthcare systems throughout the pandemic. And so that's why I was able to give you those statistics regarding communities of color. But when you start looking at socioeconomic issues, and you have to start, and some of the more location science issues, that requires a much different skill set. So there's no sort of one-stop shop for that, but it takes a couple of different shops to pull them all together. Reese, I don't know if you had any other thoughts on that.
Agreed. One of the things that the St. Louis Regional Health Commission does is we collected access to care data report that talks about specifically disaggregated data and what that looks like. There's also through, and I'm sorry, all of my resources are very St. Louis specific, given that's my frame of reference. But if you look at the Think Health website for the St. Louis County Department of Public Health, there's also some data that you can get that's also disaggregated as well. I think that's the most important thing that I would really recommend, is that for all of the data, we have an opportunity within our healthcare systems and organizations to disaggregate our data. And what we learn from that is really meaningful and powerful, that can help inform decisions both on an organizational and a systemic level.
Question here from John, and it is, how does one go about refocusing the conversation about COVID away from taking cheap shots at Dr. Sam Page and Dr. Anthony Fauci? I was just in one yesterday where some of the people believe it's okay to allow high school students to play contact sports for the sake of their mental health versus physical health, and claiming that the young are at lower risk, but what about them spreading it to others? Jeanette, Kiana, what do you think?
Well, so much of this has become a personality contest, making sure I'm not on mute. It's really about the science and not necessarily about those individual personalities. I think they are, our medical community, including our CDC, the organization, the federal organization that's supposed to be leading in this space, has been muted and muzzled, and that's unfortunate. So it is really working to restore trust and restore the voice and the leadership of our scientific community, and merging this chasm between the grassroots organizations that Risa and Dr. Garza have so aptly spoken about, and Diego, and bringing that scientific community even locally, our local health departments, to the tables that Dr. Berkeley Patton is at, to bridge that chasm and get in one space and talk about creating opportunities and creating environments where we can build the trust from the grassroots leaders, the key trusted messengers in communities, with our scientific community for local action. I think that would be a great first step. And knowing our medical directors for our bi-state area, at least in the UG of Wyandotte County and the city of Kansas City, Missouri, I think both those medical directors, our health department leaders would welcome that opportunity and have been forging such conversations with our FQHC leaders. And I think the grassroots component is what's missing and is an opportunity for us.
Jeanette, anything else?
Yeah, and I agree. And I think this is also an incredible time to not only just lead with science, but break science down, and so that it really is digestible for your average layperson. There was a great town hall meeting that was sponsored by the National Institute of Minority Health and Health Disparities that included speakers from the NAACP, from Morehouse, from other leading historically Black institutions that really did a fantastic job in just breaking down the science. And I think in doing that, we'll really be able to increase the awareness and understanding about COVID-19 and the importance of getting tested and the importance of getting vaccinated in the long run.
Got a couple more here. Richard writes, it would be great if the economically privileged would undergo and report back on trainings they've taken to uncover their own biases and start to integrate what they've learned into building relationships, etc., as described here. Does anything like this exist, he asks? What are the roadblocks? Risa?
What a great question.
Yeah.
I'm actually encouraged, I will say, from work that I'm seeing take place within the region that I have the privilege of playing a small role in within our federally qualified health centers, thinking about what does equity look like and what does it mean? How do we hold ourselves accountable to having more healing environments for all folks, right? It says health, we think about healthcare, it's supposed to be healing, but if you come into a space and you're experiencing racialized trauma, then what does that mean and how does that impact trust and relationships? So I think people are leaning into the conversation. The barriers are that the thing about implicit bias is that it operates in darkness, like it's uncovered. And the reason why it works is because it's not something that's blatant and that's in your face. It's until we're willing to lean into the conversation and we're willing to be transparent and honest about what some of our biases are that we're then able to partner together to address them. And I'm starting to see shifts in the conversation and in the landscape that with some of our hospital partners and some projects I'm working on and with our federally qualified health center problems, our partners, they're leaning into this conversation to try to identify, one, it's important to understand not just internally that interpersonal bias or relationship, but also critically important is examining, uncovering, and I would say rooting out the institutional biases that are allowing for the disparate outcomes and injustice, the health and social injustice, to Ms. Thompson's words, to continue and to perpetuate. So there is work to be done, but I think the conversation, I'm cautiously optimistic, is shifting and people really are rolling up their sleeves, and it's hard work, y'all. But people are willing to do this work because we understand that we as an entire community, all of us suffer when we are not willing to do this hard work, to transform our health systems into ones that are healing spaces for every one of us that walk through the door.
I want to get to one more because, and our time is growing very short, so a bite-sized answer would be appreciated here. You knew this question was coming, and it comes from my colleague at KCUR Public Radio, Dan Margulies, here in Kansas City. And Dan's question is this: how do you build trust when the top political leaders of the country are super spreaders of misinformation? Any volunteers for that one?
I think we have to find our local experts who are diverse, who are Black, who are brown, who are in government, who are in public health institutions, who are leading at FQHCs. And when I say leading, I'm not just talking about CEOs, I'm talking about prima donnas. I'm talking about community health workers. I'm talking about mid-level staff. They are our local experts. And I'm a big advocate of local problem solving. So how do we collectively forge public, private, governmental partnerships that address this issue of bridging science to grassroots and addressing this for communities of color? So who are our local experts? Let's get them in front of our community.
Okay, we're going to leave it there. I want to thank
who are our local
Jeanette. Yeah, go quickly.
I was going to mention also who are our local popular opinion leaders and getting them trying to help get that message out so that, again, the message is coming from people that others know, see regularly, and trust.
I want to thank our terrific panel here today for some great answers to some tough questions. Dr. Alex Garza, Diego Abente with Casa de Salud, Dr. Jeanette Berkeley-Patton with the UMKC Health Equity Institute, Risa Rollins-Easley, the Chief of Staff for the St. Louis Regional Health Commission, and Kiana Thomason, President and CEO of the Health Forward Foundation here in Kansas City. And just a quick note that our next topic will look at abandoned houses and structures in our two big cities. Information will be sent via email when we have the date and presenter set for that program. In the meantime, thank you all for joining us today. This has been a great way to kick off our big two-city collaborative project here. Thanks for your time. We'll see you again in a few weeks.